Welcome. There is a young group here who is interested in meta-analysis in this beautiful afternoon. We will be trying to discuss the basic concepts and also the advantages and disadvantages of new meta-analysis methods. My name is Ayşegül Yıldız. I'm a professor in 9 Eylül University Department of Psychiatry. I'm interested and involved in standard meta-analysis since 2000, and I'm also working on network meta-analysis. I think that we will have an effective discussion platform. I'm going to talk about basic concepts first and then leave the floor to my colleagues. As you know, randomized controlled trials are the most powerful evidence in clinical efficacy. However, randomized controlled trials are really costly, therefore a few of them are conducted, and sometimes the data out of these randomized controlled trials might be confusing, because in one of them drug A is superior, in the other drug B is superior. So we cannot understand which one is superior. To understand it, meta-analysis is performed, and for years there are three groups of meta-analysis. Network meta-analysis concept appeared after 1990s, but it's been used for the last couple of years. Standard meta-analysis is an older method. In systematic reviews, the existing data is evaluated in a systematic manner without any pooled analysis or without using statistics. There are some concepts in the network meta-analysis and standard meta-analysis, and I would like to elaborate on these concepts, because without full understanding of these concepts we cannot understand what these meta-analysis mean. We have concepts for continuous variables, and the most important concept is mean difference. I'm using the English word terminology because we don't have a full translation for that. For drug A group, there is an average score, let's say 30, or if it's a depression scale, there is an average which is 30, and also at the end of it there is another group average which is 20, and the difference is 10. Let's say it's 27, and for the end point at the end it's 10, 17, and then it's 10. A mean difference is the difference in between, for the beginning and difference between the beginning and the end. If we extrapolate it on standard deviation, we find the mean standard deviation. But this is the mean of the changing scores, not the group mean. Change in difference is baseline minus endpoint. The difference between both groups is found for deltas, and then we calculate the standard deviation of it, and this means that we calculate the standard mean deviation. And the rough calculation for that is Cohen's d, and the adjusted version according to N is Hedges adjusted G. This is a different version of standardized mean difference. So these are continuous variables, and we also have intermittent variables. Risk difference is one of the concepts. Rate difference or event difference. They all mean the same thing. There are responders in one group. when there is a decrease more than 50% in the scores, there is a response. Let's say in group A there are 100 people and 30 responders, so they had a recovery of more than 50%. Then 100 divided by 30 gives us the response rate for A, and we calculate the response rate for B similarly, and the difference between these two response rates give us the risk difference, rate difference, or event difference. And when we proportionate these two response rates, drug A responders and drug B responders, when we look at the ratio, then between these two we have the risk or rate ratio. Let's say for antipsychotics the response rate is 50%, and for placebo this response rate is 31%, and the proportion of the ratio of these to each other is 1.61 times, or 61% more responders with antipsychotics, so there is a 61% difference between placebo and antipsychotics. If the outcome is negative, like mortality, and if the mortality rate is 2% with drug A, then drug A, and 3% with drug B, and the ratio between these two is 67%, which is the relative risk reduction with drug A. And there is also the odds ratio. Response rate is the ratio of the responders to total number of patients in group A, and odds ratio is the ratio of non-responders in group A and group B, and the ratio of these two is odds ratio. So in one we calculate the ratio between the total rate and responders, and the other with non-responders. The number needed to treat, number needed to hazard are two other concepts. And this actually, the difference between A and B is risk difference, as you know, or rate difference. One over risk difference is NNT, number needed to treat. This is the number of patients needed to get a result that is +1 when compared to the control group. So you have to get even one more response in the treatment group when compared with the control group. If the outcome is a negative outcome like mortality, and if the mortality rate difference between A and B is 2%, then 1 over 0.02 means that 50 people should be treated in order to prevent one death. And there is also NNH, number needed to harm or hazard. How many people should be subject to this treatment or risk in order to see a harm that would normally not occur in one person? So as I said before, there is standard meta-analysis, and these are called standard pairwise or paired meta-analysis as well. And basically, drug A and placebo, or drug A and drug B are compared here. But when we look at the articles, we see that a series of drugs are listed, HSG or odds ratio, whatever you are calculating, you see the calculations. But as you see, there are multiple meta-analysis here, not a single meta-analysis, because each pair is compared with one another and they are compared individually. For example, tamoxifen was compared with placebo, risperidone was compared with placebo. As you see, there are pair comparisons here, or dual comparisons, because the meta-analysis is a dual meta-analysis, and there is also multiple treatment meta-analysis. analysis. And here multiple drugs are compared here, like the one here. Multiple treatments are compared with one another, and there's data for each of them. And when you analyze them all at the same time, this is a network analysis. All these lines show the controlled trials where these drugs were compared. This is one of the first networks for psychiatry. Spriani and co-workers designed it. Only active drugs and placebo were compared without any control group. This is a network analysis. In network analysis, drug A is compared with drug C, and drug B is compared with C, or let's call C placebo. So both drugs are compared with placebo, but there is no study directly comparing drug A and drug B. A network analysis takes the common denominator as C or placebo, and using that common denominator comes up with an idea about the difference between drug A and B. This is based on many assumptions, of course, because there is a network analysis that includes actual trials and also some fantasy trials. These fantasy trials are not real trials. Therefore, their results are assumptions. And the most basic three assumptions is transitivity in treatment effects, similarity, and consistency. I'm going to explain them. Without these three assumptions, network analysis results cannot be reliable. Transitivity is, there are two groups of trials comparing A and C and comparing B and C. The trial environment, patient characteristics, they all need to be similar so that the effect can be transient. Otherwise, our indirect idea of A and B would not be valid or true. That is why the trials must be almost identical to one another. The patient characteristics and the trial environment should be similar, and the results have to be analyzed by so many tests so that they are consistent. And whatever method is employed, that method should be consistent with the standard meta-analysis results. Values calculated in network analysis, and as I said before, some multiple drugs are compared with one another. Some mathematical formula have been used to compare them with one another simultaneously. For instance, ziprasidone and risperidone has never been compared with one another, but the network analysis enables us to take placebo as a common denominator and try to come up with a mathematical value as to the difference between these two drugs. And this mathematical value is this. Let's say we have put the drugs in an order like this, and the continuous variables, standardized mean difference, shows the difference for each drug. For instance, the difference between lithium and haloperidol, and the underlined ones are significant differences, and on top you see the odds ratio and dropout rates. Odds ratio according to dropout rates. But the main thing here is efficacy, of course. All drugs are analyzed simultaneously here. Each has a value vis-a-vis each other and also vis-a-vis placebo. And you see the value vis-a-vis placebo, and dropouts also with the same method have been calculated. You see the odds ratio for each other, and a different criterion could have been used for different variables. So after having gone through the these basic concepts, I would like to give the floor to Professor Cengizhan Açıkel. He is from Department of Biostatistics in the military hospital, and he is going to talk about potential contributions of standard meta-analysis to psychopharmacology, and he argues that these contributions are more, risks